The first one I had was how can we encourage all mental health professionals and teams to look towards long-term outcomes rather than short-term interventions? Just an easy one to start. So,
That's an interesting one.
yeah, so anyone wants to speak to that, and the microphone will appear.
Most people's behaviour is driven, unfortunately, by performance and drivers. So you've got to have the drivers that support that, and that comes from both policy drivers, you know, in terms of if that is mandated in policy. It's also in terms of trusts, in terms of provider trusts, actually their messaging about what's important. It's also in terms of what providers get inspected, so the CQC. You've got to have all of these players aligned, saying that this is what needs to happen, and you will drive behaviour of clinicians. So it's, you know, that's what we see, that when you align all of these things, so people know that they're going to be expecting that there's policy imperative on it, that there's resourcing for it, that they'll be held accountable for it, and there'll be performance managed on it. All of those things will help. The other thing that does help is about training for values and attitudes, and that's something that doesn't cost, which is about people really thinking about what they're dealing with, what they're trying to do, what was our raison d'etre, what we're trying to do. And I think something that some services do exceptionally well, but I think it's something that you need to spend time within a team culture about, thinking about what are we actually trying to do, what are the needs we're trying to meet, and how do we try and meet that within the resources that we've got. So I do think there's something about within teams, and that comes from leadership, management, but also the culture within the teams. But to move with resourcing from short term, which has been, I think it's tipped that way, requires a shift the other way. And that requires a shift to recognise that we're talking about, let's say, long-term course, and therefore we need the vehicles, but we also need the levers to drive that.
I don't disagree with anything you've said, but I think, first and foremost, moving towards like an outcomes-based approach involves a huge cultural change in terms of services. It's not what we're used to doing. I think people think of services as being performance-driven, and I think when we're thinking about outcomes, we need to think about things that are meaningful to service users and carers. So it's about having that, listening to service users and carers about what's important to them in terms of the outcomes. I also think we have to be really careful when we're thinking about outcomes, because this should be about making a difference and making a meaningful difference. So I think the whole outcomes agenda has to be driven by, again, thinking about starting off with care planning, a discussion in terms of understanding where a person's at, and really thinking about where they want to be, rather than it coming from the performance department saying we need to do outcomes. This should be about, are we actually making a meaningful change to service users who are coming through our service? Then you've got all the levers and drivers that Joe's talking about. So yes, they're important, but I do think we need to engage service users, carers and staff in this whole agenda, and not be a top-down driven process. It has to come from the bottom.
Thank you very much. I've got one that's about the north. How can we make sure there is, with the grants for central governments being, funding being slashed, and is there anything we can do to address and build on this kind of momentum in the north of the country to respond to these service needs, or getting carers groups together?
There is one care group I know of, a service user group up in Newcastle, and they link in with the commissioners. And part of me thinks that if CCGs were more on the ball, they would be developing carers and service users to talk to, but they're not actually doing that. So I think that really it's up to carers, and if you know carers in your area, to get together, or even write to the trust and say, look, we're not involved in the commissioning process. Could you please put us in touch with the local commissioner, because we believe we should be consulted about what happens in mental health services. And I think there's a lot to be said about carers actually getting together and creating a groundswell of dissatisfaction, shall we say, but somehow or other doing it politely but being a force for change. And in our group we talked about, Sue sort of said, why is it we find it difficult to challenge? And I think as for carers here, why is it that you find it difficult to challenge what happens? And we need to start doing more of that, I think.
Okay, thank you. Okay, Andre, do we have some questions from Twitter?
Yeah, I've got loads. So we've had some nurses, we've had some psychologists, we've had some people with lived experience of mental health issues, we've had some carers asking questions. One of my favourite ones was from a clinical psychologist who said, we often tell mental health carers how important it is to look after themselves too, but this can be hard. What practical advice would you give to carers who might feel stressed, tired, angry, scared, confused, etc., who are finding it hard to prioritise their own needs?
Okay.
Well, I can tell you what I've done, but I'm not holding myself up as a model of rectitude and best practice or anything like that. And I don't know how far this was ever planned, really, but looking back, I think what was helpful to me personally in terms of dealing with my caring role, which at the beginning, which was, I think I mentioned before, was more than 20 years ago, I felt I was in a very different place there. It was very, very difficult, and I think I've blocked some of it out. But I think it was very helpful for me to make the decision, consciously or not, to actually get into the mental health world, which it may seem a bit of an odd thing to do, to escape from your very frightening caring duties by getting into a noted mental health charity. But it was somehow very helpful because I was not shying away from the issues. It could never be escapism. It was escaping right into it. But because it was a very, very different way of looking at things, looking at the global issues rather than the personal ones, or the people's issues rather than my own, it seemed actually to help. So I'm just saying, that seemed to work for me. I escaped by getting into Rethink. Like tomorrow, I'm looking forward to my catch-up meeting with my chief executive. And that's actually sort of pitting what remains of my brains to those sort of the various issues that come up in the charity. Actually does seem like light relief in a strange sort of way. I'm absolutely spot on with where I'm at, but it's a lot actually thinking about me personally and my son. Does that make sense to anyone?
I think this makes perfect sense because I'm not involved very much in my son's care, but if I'm out there and I'm challenging the way services are, then I'm helping him in my own way, and I think that's what you're saying. And I think the other thing is, yes, it is very, very, very hard to look after yourself, but you actually do deserve to look after yourself. And taking yourself away for a week somewhere, nothing can seriously go wrong, but actually doing that and having the courage to do that will make a huge difference. And that's only because I've done that for the first time in 20 years. I went away for 3 weeks to Thailand and I thought, great. But I came back very contented and sort of ready to take the challenge on again. So please do not be frightened of looking after yourself.
I was just going to pick up the point about, I suppose the principles behind the sort of React toolkit were about bringing information all into one place so that people can readily access things that might be useful to them, whether it's about sort of how looking after oneself or information about your relative's condition along with the sort of interactive support. So I guess one of the consequences of that was people were reporting in the qualitative feedback that they were feeling less isolated and less alone, even people who've been living with this for quite some time. So I guess there's a sort of range of different ways that might be helpful, but that might be part of what might be useful for some people.
Okay, thank you very much. Andre, did you have...
Okay, so there's been a couple of points about whether the conversation has been including a diverse range of views. So we had a tweet that asked, have the experiences of diverse groups been mentioned today? If not, why not? Thinking about BME carers' views being particularly well represented as well.
Okay.
Well, I think that's a really good point, and I don't think they have been particularly overly well represented today. And I think, you know, if we're thinking about ways forward in the future, that does seem to be a perfectly sensible way of extending what we're doing. So I don't think there's been an intention not to, but my experience of the day is that we haven't maybe done that as well as we could have done.
So we'll take that forward as part of our feedback about the day and make sure that for others putting on similar events that we learn and share from that experience.
I was going to say it didn't come up in our discussion, and probably looking round as well in terms of, I don't know how people were invited or found out about it, but maybe that's also something about making sure that actually we reflect the whole economy that we're trying to support. So I think there's just messaging about events like this, how we organise it, how we advertise it, how we promote it, and how we ensure voices are represented. It was nice that there were siblings and young carers here, but it would be good to have a whole economy. Yeah, I think it's a valid point.
Okay, thank you very much. The last question I had was what informed support can professionals give for working age people with treatment resistant psychosis? It's a very specific question, but I think that a lot of it came up about life course, in addition to Philippa's question about what happens when I'm not here. There's also what treatment or services are available for people of working age, so who are experiencing mental health difficulties.
Okay, I was hoping you would do that. So are we talking about people who are not responding to any kind of interventions?
Any kind of medication?
Or any medication?
Yeah.
I think for me, one of the key issues is about hope. And I really think that as a kind of workforce, we always must kind of maintain hope. I don't think we should ever suggest that anyone, that's it. And I think, unfortunately, mental health professionals sometimes only see people when they are ill, and they don't actually ever see people who are doing well later on in life. I always remember a figure when I was kind of doing my training, which was about kind of seen as chronic patients. And these were the people who people gave up on, who had seen as being ill for year after year after year, and in the States they were classed as backwards patients because nothing had ever happened. And yet when this group of people were actually followed up for over 20 years, what they found was that 16% of that group actually did really well on long term in terms of, and this was in the days of talking about clinical recovery. So these were people who, after years of not responding to anything, actually their symptoms reduced and they were back into kind of social recovery as well. Now I know that means that there's 85%, 84% of people who didn't, but the point is you don't know who those 16% are. And I think we have to always kind of hold on hope for everyone, because we just don't know. So it's not about giving up on people. It's about working alongside them and meeting their needs at that time. It's also not about just kind of referring people back into the community and forgetting them. It really is about looking at where that person is and what they need at that moment in time. And sometimes, as I said earlier, that goes beyond just looking at symptoms. It's looking at the whole person and really trying to find something that gives them some meaning and purpose in life and kind of connection.
I'm going to say three different scenarios, which is when I was in early intervention, there was a lad who sat in front of me who hadn't sat his GCSEs. I asked him what he planned to do, and he said he was going to be an astrophysicist. And I remember inside I probably raised an eyebrow and thought, you've had a psychosis, I wonder. You know, and I was thinking, but as a team we worked to get him through his A-levels, and in fact he went on and I worked with him till his first year of university, and then 2 or 3 years later I got a photo from his mum where he'd graduated with a first in astrophysics at Birmingham, a master's, and then he went on to do a PhD and is now an astrophysicist. And I think it's one of those things about attitudes, you know, and in terms of maybe judgments that we make. So I'm going to give you another scenario, which is we were introducing the Endeavour trial. I'm very much into getting people back into education and work. And the first person that we got into work was probably the most symptomatic person on our caseload. He was like the one that you would have least thought, because it used to be like you'd wait till people were well and then you thought about getting rid of it. And I don't know how it happened, but the very keen employment worker got one of the most, what you might judge as the most poorly person into work, and he stayed there. That shifted the attitudes of the team tremendously, because suddenly it shifted that complacency or that acceptance in terms of maybe making judgments about how people are now or about their scope and how far they'd go. And the final story was a mum who does a lot of training now for family intervention, who had one son who was diagnosed with schizophrenia and at 35 was sort of living in his bedroom, not in work. And then she had a second son who developed a psychosis in adolescence, and she was very, very pessimistic because of her experience of the first son and thought, you know, how bad luck is that, 2 sons. But he actually had early intervention services and actually did go on to do A-levels, go to university, get into work. And she kept asking, what's the difference? Same family environment, same thing, but it was something about model of care, attitudes, beliefs. And I do believe that in this, that as clinicians, I agree with Alison about giving hope to people, about believing and trying enabling a future for people. But there is something about complacence and how we get stuck in our attitudes. And when we developed the early psychosis declaration in the early 2000s, we set an ambitious target on suicide rates, because I was trained, I used to see young people, and I knew that the suicide rate for young people with psychosis was between 10 to 15%. And I used to see, sort of count the young people I was seeing and think, which one might not be here in 5 years? Because that was what I was trained in. But actually, we've driven down suicide rates in early psychosis to below 1%. And I think there's too many things that we accept because either we were trained in it, or maybe, you know, maybe we don't have the courage of conviction, or maybe we just get stuck with maybe limitations like I did when I raised the eyebrow on that lad. And I think there is definitely some elasticity that we need to capture in terms of creating hope in families, in terms of trying to help young people at whatever age, move forward. And I was chatting over there and sort of saying, trying to find identities which are not fully in terms of I'm someone who's had bipolar or I'm someone with psychosis, but you're here seeing me here, but I'm a mum, I'm a wife, I'm a cyclist, I've got so many other identities. It's about how we enable and bring forth those other identities where people can be a contributing family member, or they might be in a working role, it might be in all sorts of different ways, and we need to help people develop those other identities that aren't stuck in being unwell. Comment.
Okay, thank you very much. Okay, so thank you, panel. Philip, go for it.
Yes, I wasn't sure whether to say this or not, because I think those were very heartening words from all of you. One thing I just wanted to say was that sometimes you hear that, I'm thinking particularly about schizophrenia, it gets divided into 3, like gall gets divided into 3 parts. The people who have an episode and then thoroughly recover, the people who never recover, and the people who are in the middle with proper care and medication live a very happy and useful life. I just wanted to make a point about that perhaps many of us here fall into the category of, which is a different category or a subcategory, and I suppose I've already said it in a way, talking about my own son. He doesn't fit into any of those 3, in that he is not now actively psychotic and hasn't been for 10 years, but he's not like he would be if none of this had happened. In other words, he has considerable cognitive difficulties and is therefore quite severely disabled and can't work. But is a darn sight happier than he used to be. But I think a lot of carers nod when I say that. There are many of you I speak to who have children who, with all the medication and everything have been tried, are enduringly psychotic, and I feel so sad for them. But there are people, and I see one or two nods, that can share my experience of a severe and enduring illness, where the main illness component does get sorted. It takes a long time, but it does. But the person they're living with has enduring difficulties. And I don't want us to forget those people, because I think those people make up a lot of carers groups and people who join organisations like Rethink Mental Illness. But just in case I sound like a bit of a downer after what you said, Joe, and what Alison said, my son today, when I finally got round, my phone was vibrating like mad, because I turned it on to vibrate, so not to interrupt anyone. And when I finally rang him at lunchtime, he said, Mum, I've had such a lovely morning. I've been to the allotment. He belongs to a community allotment, and they take people with mental health issues. Now, my son sort of sat in a chair for about 10 years, and then he just trudged off to somewhere else, at some sort of support group for another 5 years. He would never do any gardening, any allotmenting. He wouldn't really get out of his chair and switch off the television. He said to me this afternoon, I've had such a lovely time. I've been picking up fallen apples, and then I did a bit of grass cutting. It was such fun. He was happy.
Brilliant.